Hi, this is Barbara Quinn, and my policy presentation is going to be on a proposal for a new policy to add non-ventilator hospital-acquired pneumonia as a new quality metric in healthcare. Hospital-acquired pneumonia is the most common hospital-acquired infection in the United States, affecting 1 in 4 of all hospital-acquired infections, or 25%. And they cost healthcare systems more than any other hospital-acquired infection. Mortality is 20%. Length of stay is an average of at least one more week in the hospital. 40% of these patients with NV-HAP are discharged to a higher level of care than what they were admitted from. And 20% of them will be returning to the hospital within 30 days. However, despite all of that, there is currently no quality metric for non-ventilator hospital-acquired pneumonia, or NV-HAP. Quality indicators or healthcare metrics are used to measure clinical performance and care quality. They also inform in order to continue improvement. We need those metrics to drive systematic improvement and decrease costs. The first history of quality metrics that I could find was from 1846 with Dr. Semmelweis, who, of course, as you all know, tested hand hygiene to see if he could improve the outcome, which was a reduced number of hospital-acquired or healthcare-acquired infections. And after that, shortly after that, Florence Nightingale demonstrated that improving sanitation could reduce mortality and infections in the Crimean War for the soldiers. So there's been a lot of changes since 1846, but healthcare metrics are still an important strategy for improving quality and reducing harm and responding to a demand for better patient care. I found 5 common agencies with quality metrics that I thought might apply to NV-HAP. There's the National Database of Nursing Quality Indicators, or NDNQI, as some of you may be familiar. This is a voluntary database for capturing care outcomes most affected by quality and quantity of nursing care. Pneumonia is a nurse-sensitive outcome, but NV-HAP, unfortunately, is not an included indicator for NDNQI. They only mention ventilator-associated pneumonia. The Joint Commission is another agency who has many performance standards. The one I thought this would fit best under would be a national patient safety goal, but they don't mention NV-HAP under the Joint Commission and never have. CMS has quality measures, obviously, but the only ones they have regarding pneumonia are patients who come into the hospital with pneumonia, so nothing hospital-acquired there. The AHRQ has a quality scorecard for HACs, or hospital-acquired conditions, and many of us are quite familiar with those, and they include many hospital-acquired conditions like CAUTI, CLABSI, C. diff, falls, pressure injuries, etc., but they do not include NV-HAP. That same agency also offers QI monitoring quality indicators using administrative data, but unfortunately it also does not include NV-HAP. The National Quality Forum is the 5th one that I found that I thought this might apply to, but they do not list this particular quality metric, or do they endorse anybody else's quality metric on NV-HAP. So why, you're probably asking, is this so important? I say there's probably 3 reasons where I think having a new quality metric for NV-HAP is really important. First, NV-HAP is costing more lives and dollars than any other hospital-acquired infection in our country, and it's not shown any improvement since the first publication or measurement of it in 2012, which is not surprising because, secondly, if there's no measurement, there's not going to be any awareness and there's not going to be any improvement. However, if it's a metric, it really elevates that to the same level of concern and attention as other patient harm. And then thirdly, that awareness and it's an awareness and a requirement that organizations measure. That gives nurses a new leverage and a platform to really get what they need to improve these types of care processes. So I wish there was some current legislation or policy in process, but unfortunately there is not at this time. It's not, there's no initiatives to include NVHAP as a nurse-sensitive outcome, an accreditation standard, or a CMS reportable condition. So I'm thinking probably 3 possible agencies might be likely sponsors of such a quality measure. First, I think of the Joint Commission. They have national patient safety goals, or they could put out a practice alert. And we know when Joint Commission speaks, people listen. I also think CMS may be a good candidate and be interested. After all, if this costs this much money, you'd think that they would be interested in reducing their costs, right? I was thinking they could add this to their hospital-acquired condition. And the nice thing about that is it's automatically collected with administrative data, so there's not as many resources involved. And I also thought maybe the AHRQ could add this to their QI monitoring program. And I think of those 3 categories, best fits in patient safety indicator, maybe adding it to the existing post-op respiratory failure to try to capture post-op pneumonia, which right now they do not include in that. The history that I know of is only involving the Joint Commission and CMS. I know that Joint Commission is aware of this issue, the incidence and the cost, but they're really hesitant to take a public position or put out an alert until there's more national support. Since they're an accreditation agency, they don't normally are not the ones who say everybody has to do this until somebody else says they need to. And CMS already has a current definition, actually, of non-ventilator hospital-acquired pneumonia in their NHSN definitions and database. And they are aware that the incidence of NVHAP is much higher than VAP, which they spend a lot of time on VAE and VAP. In fact, they've published reports themselves about it, so I know they know. But currently, NHSN does not require reporting. And so the definition's there, but nobody has to use it. So in identifying key stakeholders apart from these agencies, who do I think may be interested in helping move this forward? I think of 3 main groups. One is APIC, that's the Association of Professionals for Infection Control. They are they're the largest infection prevention association in the United States. And in 2019, they put out a position statement on NVHAP and put out a call to action for infection preventionists, which is a huge step forward. And then shortly after that, just this last year in 2020, they published the first NVHAP prevention guideline. So again, huge statement, and I'm hoping that Joint Commission is watching that. Secondly, the American Dental Association is very vested in this policy. They, in fact, endorsed the first oral care protocol for hospitalized adult patients back in 2017. And as we know, dentists truly appreciate the importance of oral care to prevent all sorts of issues, but they also understand the connection between oral care and pneumonia, so they're very big proponents. The ADA members also sit on boards for CMS and the Joint Commission and other regulatory agencies, so they may be well positioned to help with this. And then there's a whole group of scientists and researchers that have been working on this, sort of a small but mighty group across the country and some in Great Britain and Australia. Michael Klompus from Harvard is a foremost researcher on pulmonary disease and did a lot of publication in VAPS. And he published an editorial on NVHAP saying, quoted, "the next frontier." is what he called it. So I know he has great interest. There are several hospitals across the United States and some researchers who have been successfully piloting these projects and seeing improvements, but that's about as far as it's gone right now. So the potential effect of this metric, I'm thinking four reasons why this could be very impactful. One, it's going to increase awareness, which is huge. Most people have no idea that non-ventilator hospital-acquired pneumonia is the big deal that it is. Second, I think that a metric would inspire clinical innovation. People will figure out how to measure, how to monitor, how to do surveillance, and how to prevent it. Thirdly, I think it will incentivize organizations to include NVHAP in dashboard priorities, and that therefore they will allocate resources for that. And then fourthly, which is really important, I think it will promote an investment in grant funding for higher level research. Right now, there's no grants out there for this because nobody is aware, nobody is being required to do anything about it, and so there is no grant money out there for it. So who do I think would be helped by this particular metric? First of all, our patients will be helped because by preventing NVHAP, we will decrease mortality and morbidity, of course. And nurses, I believe, will also benefit because this metric will give them the leverage they need to get the assistance and the tools they need to prevent pneumonia. And thirdly, healthcare organizations will benefit because their patients will have lower mortality, they'll have lower 30-day readmissions, it will reduce overall costs and increase affordability, which of course is a huge thing right now. There are financial implications. Honestly, and the truth is, we all know it, metrics cost money, and it takes resources, right? So that's why I would recommend adding to an existing category, such as CMS hospital-acquired conditions or HACs, where the data is automatically collected from ICD-10 administrative data. And it would be for tracking only, right? We're not asking anybody to do deep dives into every chart. Or we could add it to the Joint Commission National Patient Safety Goal as a monitoring metric and just tell people, this is out there, we know it's a big deal. You figure out a way to measure it, you decide how you want to monitor it, and when we come around for accreditation visits, just let us know what you're doing that's showing any improvement. At least that would get the ball rolling. And I think it's a mistake to wait for a perfect consensus of a definition. I think there's a call out there, a call to action that we can do something now. So in summary, NVHAP is the most common hospital-acquired condition or hospital-acquired infection in U.S. hospitals, and it's been confirmed with retrospective studies, national prevalence, incidence studies, and bench-level databases, yet it's the only hospital-acquired infection without a quality metric. There is a national agency and professional acknowledgement that NVHAP is an opportunity for improvement, but there is still reticence to make a stand in the form of a required metric. My policy proposal is for the creation of a metric for NVHAP as part of the CMS HAC program or the Joint Commission National Patient Safety Goal as a tracking measure only. Neither will garner a penalty, but either will bolster action at the organizational level.